There are these really weird moments in human physiology where your brain just it completely misinterprets what's actually happening. Like when you touch dry ice.
Right, yeah.
It is so incredibly cold that your nervous system actually registers it as a burning sensation.
Yeah, exactly. It's an extreme stimulus that, well, it effectively scrambles the neural signal, so the body's interpretation of the event becomes the exact opposite of the physical reality of what you're touching.
And today, for our deep dive, we are exploring a medical paradox that does the exact same thing.
Hmm.
But it's happening in a part of the body that, honestly, most people are completely mystified by.
Oh, for sure, the human pelvic floor.
Right. So our mission for this deep dive is to answer a very specific, highly counterintuitive question. We want to know, can trigger points, which are literal, tight, contracted knots in your muscle tissue, actually cause a feeling of looseness or laxity?
It's a great question.
And we are pulling from a really diverse stack of data today to answer this. We've got anatomical textbooks, physical therapy guidelines, and even some emerging research on virtual reality rehabilitation, just trying to figure out how this all happens.
Yeah, and it's a question that challenges a lot of basic assumptions, like to set the baseline here. If you look at how the medical community has traditionally categorized pelvic floor issues, they usually split them into two distinct kind of opposing camps.
Okay, what are those?
Well, you have hypertonic, meaning the muscles are too tight and overactive, and then you have hypotonic, which means the muscles are too loose, weak, and underactive.
Right, tight versus loose.
Exactly. But as we dig into the actual mechanics of the pelvic floor in our sources today, we find that the reality of what patients experience is it's far more tangled than that simple binary.
Yeah, so if we're going to figure out how severe tightness masquerades as looseness, we should probably define what looseness actually means in a clinical sense.
Good idea.
Because, when a patient goes to a doctor and says, hey, things feel loose down there, what is structurally or, I guess, neurologically going on?
So the clinical term we're usually looking at in that scenario is vaginal laxity. And the literature describes this as a subjective sensation of looseness or a distinct lack of tone.
Oh, okay.
Yeah, and it's most commonly reported at the introitus, which is the vaginal opening. It's an incredibly common experience. Like, a lot of people experience it after pregnancy, specifically following a vaginal delivery.
Because the tissues have just been stretched beyond their typical limits?
Right, exactly. But it's also highly prevalent simply due to aging and menopause.
Wait, how does menopause directly cause that sensation, though? I mean, is it just the passage of time, or is there a specific, mechanical change happening in the tissue?
No, it's a very specific chemical and structural change. So during menopause, the body experiences a significant drop in estrogen. And estrogen it isn't just a reproductive hormone. It's actually heavily involved in maintaining the cellular architecture of pelvic tissues. It promotes collagen turnover, and it keeps the mucosal lining thick and elastic.
Oh, wow.
So when estrogen levels plummet, those tissues literally lose their building blocks. They physically thin out, they lose their vascularity, and they lose that natural resilient elasticity, which of course registers to the patient as a feeling of looseness.
Got it. But there's a really important distinction we need to make here, though, between laxity, which you just described as a subjective sensation, and something called pelvic organ prolapse, or POP.
Yes, crucial distinction.
Because prolapse isn't just a feeling, right? It's an actual measurable structural disorder. That's where organs like the bladder, the uterus, or the rectum literally descend and bulge out of their normal anatomical position.
Precisely. They drop into the vaginal canal, and while laxity and prolapse can, and they often do happen at the exact same time, the clinical data emphasizes that laxity is not necessarily just an early warning sign of prolapse.
Okay, so they're different.
Very. You can have a profound daily sensation of looseness without any physical structural descent of those pelvic organs.
Let me see if I can visualize the difference here. So if the pelvic floor is like a trampoline,
Okay, I like that.
prolapse is when the springs actually snap and the mat completely sags to the ground, like the structure is completely failed.
Right.
But laxity is more like the mat itself just losing its bouncy elasticity over time. The springs are still attached, but the tension is just gone.
That is a highly accurate way to visualize it, yeah.
But how do hypotonic or weak muscles actually play into that trampoline mat losing its bounds?
Well, when the pelvic floor muscles are hypotonic, they are physically lengthened at their resting state.
Okay.
So if you were to look at the muscle fibers under a microscope, you'd see the tiny sliding filaments that create a muscle contraction. They're called sarcomeres.
Beers.
Yeah, these sarcomeres are stretched so far apart that they can't get a good grip on each other. And because of this, they have incredibly poor motor power.
So they literally can't squeeze.
Right. If a clinician asks a patient with a hypotonic pelvic floor to voluntarily contract those muscles, like to do a Kegel, they might struggle to even initiate the movement at all.
Wow.
Or if they can muster a contraction, the muscle exhausts immediately. Like they can't hold it for even 10 seconds. They're literally inadequate to support the weight of the pelvic organs.
Which translates directly into that physical sensation of looseness and heaviness.
Exactly.
Okay, so hypotonic means the muscle is lengthened, it's weak, and it's loose. That tracks perfectly with basic logic. But this brings us to the core of our paradox for today's deep dive.
Yeah.
Right. If looseness comes from weak, stretched out muscles, how do trigger points fit into this? Because, I mean, a trigger point is the ultimate expression of extreme tightness.
It is. And to understand the paradox, we really need to zoom in on what a trigger point actually is on a cellular level. So medical texts define them as discrete, focal, hypersensitive spots located within a taut band of skeletal muscle.
So it's a knot.
Basically, yes. A cluster of muscle fibers gets stuck in a contracted state at the neuromuscular junction. It is a localized hard knot that absolutely refuses to release.
Ouch.
Right. And importantly, they don't just cause pain exactly where the knot is located. They are notorious for causing referred pain.
Yeah, reading through the symptom profiles and the sources, people with these trigger points feel pain shooting into their lower back, wrapping around their hips, deep in their abdomen.
Yes.
And it can even manifest as painful urination or chronic constipation.
Yeah.
It's just a whole systemic web of discomfort.
It really is.
But I have a problem with this. If I have a tight, painful knot in my neck or my shoulder feels incredibly stiff. It feels like a rock. It definitely does not feel loose. So why does a knot in the pelvic floor create the sensation of looseness for the person experiencing it?
That comes down to what the literature calls the vicious cycle of a hypertonic pelvic floor. So you have to imagine a muscle that is constantly, relentlessly contracted. It never returns to its resting length. Because these muscle fibers are squeezing so tightly, 24 hours a day, they actually physically compress the capillary beds weaving through them.
Oh, man. So they're crushing their own blood vessels.
Literally. They crush their own blood vessels, which restricts their blood flow. And this creates a state called ischemia.
So the muscle is effectively choking off its own oxygen supply just by clenching too hard.
Exactly. And when a muscle is deprived of oxygen, its metabolic engine has to shift to anaerobic processing. This leads to a massive, localized buildup of metabolic waste products inside the tissue.
What kind of waste products?
Specifically lactic acid, bradykinin, and inflammatory cytokines.
Wait, slow down on the chemistry for a second. Bradykinin, cytokines. Are those just like the body's alarm bells telling the brain, hey, we have a problem down here? Or are those chemicals actively causing damage to the tissue?
They are powerful inflammatory mediators, so they don't just signal pain, they drastically lower the firing threshold of the nerve endings in that area.
Meaning things hurt more easily.
Yes, they sensitize the nerves so much that even normal movement hurts. This chemical soup is highly irritating to the surrounding tissue. It causes intense localized inflammation, which then triggers a protective reflex in the nervous system.
So the brain panics.
Exactly. The brain senses the pain and commands the surrounding muscle to spasm and tighten even more to guard the area.
Oh, no.
Yeah, so the tightness causes the chemical buildup, the chemicals cause pain, and the pain causes more tightness. It is a self-feeding, inescapable loop of tension.
So track with me here. Try clenching your fist right now while you are listening to this. Make a fist as hard as you can. If you hold that for 10 seconds, your forearm feels strong and tight.
Right.
But if you held that maximum clench for 3 hours straight, your muscles would be completely starved of oxygen and flooded with that acidic chemical soup you just mentioned.
Yes, exactly.
By the time someone asks you to, say, open a heavy jar, your hand would be totally useless. It might feel completely unresponsive or weak to the command to grip the jar, But the root cause isn't that your muscles lack mass. It's that they are suffering from extreme, exhausting tightness.
That is exactly the mechanism, because a muscle needs to be able to fully lengthen in order to contract with any real power. It needs a full range of motion.
Makes sense.
So if the pelvic floor is already shortened, locked up, and knotted with trigger points, it has absolutely no leverage. It has exhausted its energy reserves just maintaining the knot.
Wow.
Therefore, when your brain sends a signal to say you sneeze, and you need those muscles to quickly support your bladder, the muscle simply cannot respond.
It's just too tired.
Yes. Functionally, it presents as absolute weakness. It fails to physically support the pelvic organs, which gives you that exact same heavy, dragging sensation of looseness or instability, even though the muscle itself is locked in a vice grip.
So the extreme, localized tightness is literally mimicking weakness. The muscle is just too exhausted to do its primary job. That completely flips the script on how we usually think about strength and weakness.
It really does.
But it forces us to ask the next logical question.
Yeah.
Why are these muscles locking up in a vice grip in the first place? I mean, if they're overworking themselves into this ischemic, painful state, what are they trying to compensate for?
Well, this brings us to the biomechanical reality of the pelvis. See, the pelvic floor isn't just made of muscle. It relies heavily on a complex web of connective tissue.
Like ligaments and fascia.
Exactly. These structures act as a passive scaffold. Their entire job is to hold the uterus, bladder, and rectum in place so the muscles don't have to do all the heavy lifting. But sometimes that passive scaffold fails.
How does it fail?
We see this vividly in research looking at hypermobility spectrum disorders, particularly Ehlers-Danlos syndrome, or EDS.
Okay, I've heard of EDS. That's a condition where the actual connective tissue and collagen in a person's body are fundamentally built differently, right?
Yes. So collagen is the most abundant protein in the body, and it's what gives our ligaments their immense tensile strength. In someone with hypermobility, or EDS, the genetic instructions for building that collagen are altered.
So it's weaker.
The collagen fibrils just don't pack together as tightly as they should. So instead of having ligaments that act like incredibly sturdy steel suspension cables for the pelvic organs, their ligaments behave more like overstretched, worn-out rubber bands.
Oh, that's a great visual.
Yeah, they are overly elastic and they just lack structural resilience.
And, I mean, the human body absolutely hates instability. So if those suspension cables aren't doing their job to hold the internal organs up, the body has to find support somewhere else. And the muscles are the only things left to take on the load.
Exactly. The muscles are forced into a state of chronic compensation. They have to step in and work overtime to hold everything up because the ligaments are failing.
But muscles aren't meant for that.
No, skeletal muscles are designed to be dynamic. They are built to contract, perform a task, and then relax and recover. They are not designed to act as a permanent, rigid scaffold.
Right.
So when you force a dynamic tissue to do the job of static connective tissue indefinitely, it never gets to rest. And this relentless, unending mechanical load is precisely what drives the muscles to become overactive and hypertonic, leading directly to the formation of those agonizing myofascial trigger points.
So wait, in a patient with a hypermobility issue, the feeling of looseness or heaviness in the pelvis is entirely real. Like the structural ligaments actually are loose.
Yes, absolutely.
But the trigger points we find are essentially the muscles screaming in physiological pain because they are desperately trying to do the job of a ligament.
Yes. And understanding this mechanism solves the mystery of the confusing symptom profile we see in clinics. It explains why a patient can have actual structural looseness and severe muscular tightness existing in the exact same physical space.
That sounds incredibly frustrating for the patient.
It is. The patient feels a heavy, dragging sensation, a legitimate lack of support because their ligaments are lax. But when a clinician performs a physical exam, they find pelvic muscles that are tight, shortened, and exquisitely tender to the touch.
And this is where the standard advice becomes actively dangerous, right? If you go to a doctor and just say, hey, I feel loose down there, the knee-jerk advice for decades has been to do Kegel exercises.
Oh, yeah.
But if your muscles are already in an ischemic state, completely drained of oxygen and knotted up from compensating for loose ligaments, trying to force them to tighten more is just throwing gasoline on the fire.
It is honestly the worst thing you could do in that specific scenario. You cannot strengthen a muscle that is locked in a hypertonic spasm.
Right, because it's already maxed out.
Exactly.
Yeah.
Asking a knotted, oxygen-starved muscle to perform a Kegel is just asking it to cramp harder. It will increase the ischemia, increase the pain, and ultimately make the functional weakness worse.
So we have this highly complex paradoxical mix of structural looseness and exhausting tight muscle knots. And according to the clinical data, this physical paradox is so confusing to the nervous system that it actually starts to scramble the communication signals between the pelvic floor and the brain.
Yes. This is a vital neurological concept called the cerebropelvic axis, or the CPA. The CPA is the dynamic two-way communication loop that connects your higher brain center, the cerebral cortex, down through the spinal cord and into the pelvic effectors.
Okay, so it's the highway between the brain and the pelvis.
Precisely. And when you have these persistent, incredibly painful trigger points firing off constantly, they create what researchers classify as a bottom-up disturbance along this neurological axis.
Try to picture this like a computer network. The pain signals from the pelvic trigger points are acting like a DDoS attack, a distributed denial of service attack on the brain.
That's a great analogy.
There are just so many error messages and pain alerts flooding the system from the bottom up that the brain's processor gets overwhelmed, and it literally drops the normal functional connection to the muscle controls.
That is a perfect way to visualize it. These constant, painful interoceptive signals, the signals that tell your brain about the internal state of your organs and tissues, travel up from the pelvis and bombard the brain's insula and the anterior cingulate cortex.
And those are the areas that handle pain.
Yes, these are the higher brain centers responsible for processing pain, emotion, and determining what sensory information is actually important. This relentless barrage of pain data effectively hijacks the central nervous system.
Wow.
It causes immense physiological distress and completely scrambles normal motor function.
So what does that drop connection actually look like for the person walking around trying to live their life?
It manifests as profoundly impaired proprioception.
Proprioception, that's your awareness of your body in space.
Right. Exactly. Proprioception is your brain's internal map. It's the ability to sense where your body parts are and what state they're in without having to physically look at them.
Right.
But because of the constant pain and tension flooding the cerebropelvic axis, the brain literally loses its map of the pelvis. It loses the ability to sense whether the pelvic floor muscles are contracting or relaxing.
That's wild.
The clinical data reveals a startling statistic. 70% of women presenting with pelvic floor dysfunction cannot correctly contract these muscles when asked.
70%? Oh, wow.
Yes. Their brain sends the signal, but the connection is so scrambled that the wrong muscles fire or just nothing happens at all. They have effectively lost the mind-muscle connection.
That is a massive portion of the patient population.
Yeah.
It's the vast majority of people suffering from this feeling of looseness and pain can't even purposefully control the muscles causing the problem. So again, handing them a pamphlet on Kegels is completely useless. If the brain's internal map is blank and it doesn't even know where the muscle is or what state it's in, how do you even begin to treat this?
Well, the first absolute non-negotiable step in rehabilitation is that the trigger points must be inactivated.
You have to put the fire out first.
Exactly. You have to shut down that screaming alarm system in the tissue so the brain can stop defending itself. This is typically achieved through specialized manual therapy. A pelvic floor physical therapist will use targeted soft tissue mobilization or sometimes dry needling.
Going directly into the knot.
Yes, going directly into the trigger point to mechanically force the sarcomeres to let go. Releasing the knot restores the blood flow, clears out that acidic chemical soup we talked about, and stops the pain signals.
And then the brain can finally relax.
Right. Only once the muscle is out of spasm and the pain is managed can you actually begin the neurological work of fixing the brain-muscle disconnect.
Now, I was reading through the rehabilitation research, and this is where the technology becomes super fascinating. Because to fix that brain map, they are using biofeedback and virtual reality.
Yeah, it's incredible tech.
But I'm struggling to picture this, though. If the pelvic muscles are entirely internal, how does putting a VR headset on my face help me feel a muscle inside my pelvis? What is the mechanical connection there?
It's all about providing the brain with an external stand-in for the internal signal it lost. See, because the pelvic floor is hidden, you can't visually verify what it's doing.
Like you can't just look at it.
Right. You can watch your bicep curl a dumbbell in the mirror, which reinforces your brain's map of your arm. But patients with impaired pelvic proprioception are flying completely blind.
So how do we give them a mirror for their internal muscles?
We use EMG biofeedback. A clinician uses highly sensitive internal sensors, either vaginal or rectal probes, that measure the minute electrical activity in the pelvic floor muscles. These sensors are connected via Bluetooth to a computer system. So when the patient attempts to contract or relax their pelvic floor, the sensor reads that electrical signal and displays it on a screen in real time.
Oh, I see. This gives the patient immediate visual proof of what their hidden muscles are actually doing.
Exactly.
So they can see, like, the electrical wave spike on a monitor when they squeeze, which connects the physical effort to a visual result.
You got it. And virtual reality takes this neuroplasticity training a step further. Instead of just looking at a line on a graph, the patient is immersed in a VR environment.
Like a video game.
Exactly like a game. The biofeedback sensor in their pelvis acts as the game controller. They might have to coordinate their pelvic floor contractions and relaxations to make a virtual bird fly through a series of hoops.
That is amazing.
It really is. By pairing the vertical contraction with an engaging three-dimensional visual task, it provides a powerful real-time feedback loop. It forces the brain to rebuild new neural pathways in the motor cortex.
So it's literally restoring the sensory perception of the muscle by giving the brain a clear external cue to replace the internal signal it lost during the pain cycle.
That's exactly how it works.
Wow. So what does this highly complex, paradoxical reality mean for you listening right now? Whether you have been dealing with unexplained, stubborn lower back pain, weird tension wrapping around your hips, or pelvic issues that just don't seem to make any logical sense, it all points back to the fact that your body is a deeply interconnected, highly communicative web.
Absolutely.
If a part of your body feels weak or loose, the solution isn't always to just blindly try and strengthen it. As we've explored today, sometimes the most exhausted, weakest feeling parts of our bodies are actually the ones that have been working the hardest, holding on the tightest for the longest amount of time.
Beautifully said.
And what they desperately need before they can ever be functionally strong again is simply to be understood and released.
And, if we consider the profound two-way nature of that cerebropelvic axis we just discussed, it leaves us with a fascinating final mechanism to ponder.
What's that?
Well, we know that pain in the pelvis travels up the axis to scramble the brain's emotional centers. But if that communication loop is truly a two-way street, what happens when the signal originates at the top?
Oh, like from the brain down.
Exactly. Could chronic emotional stress or severe psychological trauma rewire that loop in reverse? It raises a huge question. Could a perfectly healthy, structurally sound pelvic floor develop these agonizing trigger points and present physically as weak or loose purely as a physiological echo of an unrelenting top-down signal from an anxious brain?